Good afternoon and welcome to IHW Council's special web series, a lung cancer awareness talk show, which is supported by Roche under its public awareness initiative. I'm your host. My name is Anisha Nair Dhawan. Lung cancer is amongst the most common cancers in India, and the incidence of the disease is only growing in our country. According to the GloboCan 2018 report, lung cancer is ranked fourth amongst overall various types of cancers in our country. Now, what is most alarming is an increase in the cases of lung cancer in a younger population who are largely non smokers. Another big challenge for the management of lung cancer is that most patients are diagnosed in late stages, which is 3 or 4, when the treatment is quite difficult and death is nearly certain. Why are so many non smokers being diagnosed with lung cancer in our country? Why are the number of deaths from lung cancer far higher than those of colorectal cancer or prostate cancer or breast cancer? Quitting smoking is the surefire way to prevent the risk of reduce the risk of lung cancer. But for non-smokers, how can one reduce their risk of the disease? To discuss this, please welcome our panel of experts. We are very happy to have with us Dr. N. Aditya Murli, consultant medical and hemato-oncology at Aster CMI Hospital, Bengaluru. And please also welcome Dr. Poonam B. Maurya, consultant medical oncologist, Apollo Hospitals and Kempegowda Institute of Medical Sciences, Bengaluru. A warm welcome to both of you. Thank you so much for joining us today.
Happy to be here. Thanks, Anisha.
Now, a quick introduction of our experts who are joining us on this panel today. Dr. Aditya Murli has specialized in immunotherapy for solid tumors and has a special interest in hemato-oncology and bone marrow transplantation. He has vast experience in the treatment of lung cancer, breast cancer, ovarian cancer, lymphomas, and leukemias, with more than 500 cases to his credit. He's trained in bone marrow transplantation from Memorial Sloan Kettering Cancer Center in New York. And Dr. Poonam Maurya is a well-trained medical oncologist at Apollo Hospitals, Bannerghetta Road and Kempegowda Institute of Medical Sciences, Bangalore. She has extensive training in various academic centers. She specializes in various solid oncologies like breast, ovary, lung, colon, and hematological malignancies such as lymphomas, leukemias, and bone marrow transplant. So let's get this discussion going, and let me ask you, Dr. Murli. The first burning question, of course, is this: that why are so many patients with lung cancer being detected in late stages? When treatment for any kind of cancer, if detected early, treatment is more successful. It could be curative, but for lung cancer, some people have given a statistic saying, 70 to 75% of the cases are diagnosed in stage 3 and 4. Why is this the case?
I think there are two parts to this. Part number one, of course, is that there haven't been any successful screening programs for lung cancer. If you take, let's say, cervical cancer or breast cancer, there are very simple screening tests like a pap smear or a mammogram, which can pick up the disease when it is very early, at a very early stage, and and these simple tests can be implemented on a mass level. However, when you're talking about lung cancer, the basic investigation, which is a chest X-ray, is probably not sensitive enough to pick up lesions at a small stage. Only when they grow too big is when they get picked up. In the West, in the US, and in the Europe, there have been trials and some kind of screening programs to do yearly CT scans for patients between the ages of 55 and 74, especially smokers and ex-smokers, to pick up the disease at an early stage. However, in India, implementing widespread CT scan testing annually for a very large population is going to be a big challenge. That's one. The other aspect is the biology of the disease itself. So lung cancer, the lungs are surrounded by multiple layers of tissues like ribs, muscles, soft tissue, skin, and all of this. So which means that unless the lesion grows very big and starts causing symptoms, it is very late for a person to realize that something is going wrong. Whereas if you talk something like a oral cancer, you can see a big plump growing on the lip or in the tongue, and you tend to see the doctor much earlier. So it's about both the lack of screening programs, and the biology of the disease.
Right. Dr. Poonam, Dr. Ditya is saying that you don't have a good screening program. Breast cancer mammograms are very effective in screening it early. Should you have it regularly? And it's not a invasive test. Um, you could have CT scans on an annual basis, but perhaps these would be for high risk patients, those who are regular heavy smokers. But you have patients who are not smokers, non smokers, who still come with cancer of the lungs. So, what is the way out for, quitting smoking is definitely a way to reduce your risk. But if I'm not smoking only, how do I reduce my risk?
Yeah. So, smoking, as we all know, is a very important risk factor for lung cancer. However, we should remember that smoking is not the only risk factor for lung cancer. So, smoking definitely has a major part as a risk factor, but there are many other things which are responsible. So, many of the times we find that none of the risk factors are present in a patient, and still patient has lung cancer, is diagnosed with lung cancer. So, most of the etiologies or the risk factors are unknown. Like, we don't know why a particular patient will get lung cancer, but definitely smoking is one of the most important risk factor. Other things like your physical inactivity, increasing obesity, bad health, bad lifestyle, and indulging in too much of sedentary lifestyle and junk food, all these are subtle risk factors, not the strong risk factors as smoking is. However, now we are finding that patients who are non-smokers are also diagnosed with lung cancer. So there is something called as passive smoking or second-hand smoke. So meaning patients themselves are not smokers, but they are exposed to the smoke in their environment, which somebody else is smoking, or maybe the smoke is coming from your environmental pollution factors, the carbon plus. If you see in the villages, the exposure to the biomass fuel burning, coal burning. So environmental pollution, smoke, this is also an important risk factor, and especially for city dwellers, this is something which we cannot do much about. Yes, at a personal level, each person has in its own way a responsibility to reduce this pollution in whatever way he can. But yes, by and large, these are the risk factors which we can't do much about. But yes, obesity, lifestyle changes, healthy lifestyle, good dietary habits. So these are something which are very much doable. So nowadays we are seeing that not even the smokers, but the non-smokers are also coming with lung cancer. So this certainly tells us that smoking is not the only risk factor, although very important. There are other risk factors which are contributing to the development of lung cancer.
Right. Dr. Aditya, you spoke of, some Western countries having an annual CT scan as a screening. I'm sure a CT scan could detect other kinds of cancers as well, which could be deep-seated, be it, your stomach or your liver or, some of those. But it's still, could it provide comprehensive care? First of all, there are concerns about the exposure to radiation that you would get annually. Secondly, you could be, say, screened, go for a CT scan on 1st of January where everything is clear, and you could still develop the cancer, say, sometime in March, but you would be due for your screening only the next year in January. So how can screening work? Does it really work? What are the other ways by catching it early?
On a holistic level, any screening program is based upon the concept of number needed to treat, NNT, which basically translates in our terms as number of scans that you need to do to pick up one case of lung cancer. Let's say to detect one breast 90 mammograms, which means that to detect at an earlier stage, as in before the symptoms. There is something similar in lung cancer as well. The type of scan which is used is something called as a low dose CT. It is LDCT, in which the radiation exposure is far lesser compared to a conventional CT scan. And these programs and these research trials were designed in such a manner that if we need to do anywhere between 500 and 1500 or 2000 scans to detect even one patient's disease at an earlier stage and cure a life, it would still be a reasonably good use of resources. And this is how resource allocation is considered in Western countries. For us, however, these parameters might be different. So, apart from screening cans, the screening programs, the only other way of making sure we detect lung cancer at an early stage is probably not to indulge in any of these risky activities. I mean, PM 2.5 has been in the news quite a bit. Delhi has been suffering from PM 2.5 every time, every year around these times. And there is conclusive data to show that PM 2.5 can go and lodge in the smallest airways of the lungs, leading to cancer formation maybe a decade and a half later. So all that we can try and do is not be exposed to these kind of harmful environments. Try and be as healthy as possible, and if and when there is a screening program, go for it. But let me tell you, there are a lot of exciting advances happening in this field. Nanotechnology is coming. Nanobots are being designed to go pick up these tumor cells at the DNA level, and I'm sure the day is not far when you can be injected with a nanobot can go and home in on the tumor DNA and show you where things are.
That certainly sounds exciting, but we are waiting for wider acceptance and greater testing to come in for these new technologies. Dr. Poonam, what is the average age of lung cancer patients you see in the country? And Dr. Aditya spoke of low dose CT scans that can be done to screen for lung cancer. At what age could these start, and would they be then targeted towards the smokers?
So the age at which we used to see lung cancer patients diagnosed, earlier even the books used to say it's a disease of old age. Cancer is a disease of old age. And so only beyond 50 or 60 years of age, we were supposed to see lung cancer patients, and we are seeing it is a disease of old age. But now what is alarming is that the age at which patients are getting diagnosed with lung cancer is decreasing. A lot of younger age group is coming front with diagnosis with lung cancer. So it's no more a disease of old age. It's no more a disease which will differentiate like that based on age. It's coming to even 30-year-old, 25-year-old, 45-year-old. So yes, by and large, lung cancer is predominantly seen in the elderly. However, now we are seeing more of the younger generation in the earlier age group presentation with lung cancer. Now, coming to low dose CT scan, low dose CT scan, yes, for screening measures, it should be chosen very wisely because, as Dr. Aditya said, definitely for high risk group. Suppose a patient is a heavy smoker, so something called as pack years. There's a formula to calculate based on number of cigarettes, the number of packs smoked in a day into the number of years you have smoked. So that pack years determines how significant is your risk. So, suppose a patient is a heavy smoker and the pack years is very high, definitely he should start the screening early. And quitting smoking, as you said, quitting smoking will reduce the risk. But one thing to remember is it will never come back to zero. Meaning, even if you stop smoking, your risk is never going to be as of a normal person. So, the risk for having lung cancer is always there once you are a smoker, whether you're left smoking 20 years back, 10 years back. But yes, reducing smoking or quitting smoking reduces the risk, definitely.
All right. Reduction of smoking will definitely reduce your risk. Uh, uh, Dr. Murli, can you tell us what are the symptoms of lung cancer? If I don't go for screening, but if I know that this could be lung cancer, let it get investigated. What are they, and are there any specific symptoms? Because we've seen that patients are not diagnosed early because respiratory issues are so many. It's diagnosed as an allergy or something else, and treatment is started. And by the time you find out it's cancer and you start treating, it's too late. I mean, stage 3 or 4. So, any specific symptom that we can keep a watch out for?
Correct. So the most important thing is not ignoring and being aware of our own, how our body is reacting. Any cough which does not go away. There are seasons. There is a winter season wherein everybody gets one round of URTI. These days with COVID going around, everybody gets a flu. But any cough which persists for more than 2 weeks, which does not go away, and along with that cough, if there is sputum production, and if you find that you're spitting blood out in your cough, that is a very big warning beacon for us to make sure we don't ignore this. So cough staying for more than 2 weeks, if you're spitting blood out, especially in the background of you being background of somebody being a chronic smoker, a patient losing weight without any reason, general feeling of uneasiness, or significant loss of appetite. These things are also important. Very rarely, lung cancer does not present as a primary thing, but sometimes causes with a persistent low backache if it has spread to the bones. In such cases, these are some of these signs. Although they are all non-specific signs, there is no one specific sign to say that yes, this can be lung cancer. The important thing is that anything which does not go away in a couple of weeks with regular homemade remedies, you need to come and see your doctor.
Right. So those symptoms are ones that people should keep a watch out. And honestly, they are more extreme than your regular respiratory infections, and those kind of. Even for TB, the thing you told is any कोई भी खांसी जो 2 हफ्ते से ज़्यादा रहे तो आप डॉट सेंटर जाइए या उसका पता
Exactly.
करिए. So now I can't quite say it's completely specific to lung cancer symptom. So that's another reason why we constrain, because there is no one thing. Like there's a lump in your breast, good chance it is breast cancer. But for lung cancer, the symptom is not really specific.
And this is what leads it to being picked up at a later stage rather than an earlier stage, and that is how the nature of the disease is.
Right now, that's something that nobody can help or do something about for now. But what Dr. Punami can do is to reduce the other risk: biomass, gas exposure, a healthy lifestyle, and these are the things by which we can reduce our risk. Now, when a patient presents himself to you, and Dr. Punam, the patient is usually in stage 3 or stage 4, then how do you handle the patient? While, a few years ago, when you heard the word cancer, it meant a death sentence. People are like, we're going to die. Now, what has happened is that medicine has improved and innovated, that there are some cancers that are curable now. You live a really long time, especially if they're not deep seated cancers like breast cancer, or a very slow moving cancer like cervix cancer. So, when you're presented with a patient who has come in stage 3 or stage 4, how do you counsel him? What do you tell his family?
So, even in society today, we say, oh, it's the last stage cancer. It's the last stage means the end. Last means last. So it's not like that. It's not as bad as we speak now. Stage 3, stage 4 also, we think patient will be very sick and oh my God, patient will be so bad. But this is not how the patients present. Some patients, yes, maybe 10 to 20% of the patients will be really very sick. They will need oxygen. Their oxygen saturation cannot be maintained without oxygen. They'll be having breathing difficulty. But some of the patients, even stage 4 young patients, they will be absolutely fine. They'll walk to your OPD, they will talk normally, and all their parameters will also be normal. So every stage 3, stage 4 patient does not mean that it is a very sick patient and is not going to do well. So, of course, when patients come, they do come with some probability of having a lung cancer, and they would have already done a CT scan, and somebody would have referred, and there will be a mass sitting in the lung, and sometimes a spread to the nearby areas and even other organs, most commonly the bones. So there will be symptoms according to where all the spread is in a lung cancer patient. So we need to first get to the diagnosis of what type of lung cancer it is, get a biopsy done, and to know exactly where all it has spread. Nowadays we have a very good test, whole body PET-CT scan, which can exactly stage and tell us what is the extent of disease, where all the disease is present, which can become a baseline for us to compare the response to treatment. So once we start treatment, before starting treatment, the PET-CT, and after starting treatment, what's the PET-CT, we can compare and come to know what is the response. So a few patients will be sick, but not all. Most of the patients will be walking, talking, and you will have to ask the attenders, patient kaun hai? Who is the patient? So they don't even look like patients. They are fit.
For younger patients, that is good to know. But Dr. Ditya, what is the prognosis? You come in stage 3 and 4. And why we always talk about stage 3 and 4 is because 70-75% of the patients are in this category. So what is the prognosis? Say you're young, you have age bias side, you're 40, 45. And if you're old, say you're 70, 75, what is the prognosis? Does age play a factor at all in you being able to fight the disease? How long will you live? Is death certain?
I think that's a very important question because this is one area of science which has progressed significantly in the last decade or so. So all lung cancer is no longer just one single label as a lung cancer. Their genetic testing has revolutionized this field. Uh, Lung cancers are divided into cancers wherein there is a driver mutation. By a driver mutation, what we mean is that is there one specific gene which has been mutated, which is causing the cancer formation. And if we are able to identify that gene and treat it specifically with that personalized targeted therapy, in that case, the prognosis, is quite good. Patients' average survival is even in years. You can talking about 3-4 years, 3 to 5 years also. If we are able to identify one particular targeted gene, same way you brought out the age aspect of things. Age is very important when we are talking about how aggressively we want to treat a disease. If we are going to give only chemotherapy, are we going to give a combination of chemo and immunotherapy? Are we going to give multiple lines of chemotherapy? So when a patient of lung cancer walks into my OPD, apart from the usual things of doing a biopsy and doing a PET-CT scan, the other thing that we are trying to do is look for some biomarkers which will tell us if targeted therapies are going to work in this condition, if immunotherapy works in this condition, and in such a scenario, counsel them accordingly. And if there is no option of a targeted or immunotherapy, then say that yes, it's going to be about a year and a half. But if you use any of these latest advances, you're talking in terms of multiple years.
All right. So you're saying there are targeted therapies that can help and give better prognosis, but on an average, what is the survivability when diagnosed with lung cancer?
I mean, as I said, so lung cancer has got something called a small cell lung cancer and a non-small cell lung cancer. Non-small cell lung cancer on an average has a survival of about a year and a half. Small cell lung cancer has about a survival of about 1 year or so. If you're talking about patients with the driver mutations, then their survival goes up to 3 years. Patients with immunotherapy markers, their survival goes a little beyond 3 years as well. If you're talking about stage 3, we are talking about a 30% 5-year survival also in stage 3 lung cancer because of the advent of immunotherapy.
All right, Dr. Poonam, there are different kinds of cancers, right? One is the cancer that affects the smokers, and one is the adenocarcinoma, which is the incidence of which is increasing, which is the non-smoker dominant cancer, though even smokers can have adenocarcinoma. So you know Dr. Ditya told us about new technologies and how survivability can be increased. Now, is there a difference in these two different kinds of cancers, the survivability, the treatment, the quality of life between these two different kinds of cancers? If you're young and you're diagnosed with any of these, what's the difference or what's the similarity?
Yeah. So according to the pathology means once we get a biopsy done, it is seen under the microscope to see what type of cancer it is. So according to pathology, lung cancer is mainly divided into two types: small cell lung cancer and non-small cell lung cancer. So small cell lung cancer is a cancer which affects mostly the smokers. So around 90 to almost 95% of the patients of small cell lung cancer are smokers. And small cell lung cancer is a very, very, very aggressive disease, meaning the patients come in a very, very sick condition. In such sick conditions, sometimes even getting a biopsy done is also very difficult. We'll have to give them some emergency treatment first to stabilize them, make their oxygen saturation better. They may require some radiation therapy, and then take up for the one by one steps of diagnosis and treatment. But small cell overall, it's a very, very aggressive tumor, and the survival can be as low as 3 to 4 months or maximum less than a year, around 10 to 12 months. So small cell lung cancer, even though a lot of has come up in the recent decades about the treatment part, immunotherapy has come up in a very big way, but it is an aggressive disease. The overall survival is very poor. It's always less than a year. Very few patients go more than a year. The coming to other part, non-small cell lung cancer. Non-small cell lung cancer, basically, there are two types, two main types. There are many, although. So one is adenocarcinoma, other is squamous cell carcinoma. So both of them, in adenocarcinoma, we see all these driver mutations which Dr. Aditya mentioned. These mutations are more common in adenocarcinoma group, especially if they are females and if they are non-smokers, the chances of having those genetic mutation positivity is high. So having those targetable mutations makes the patient more accessible and a proper candidate for a targeted therapy. And these targeted therapy, you will be surprised, most of them are oral tablets. So patient doesn't have to be admitted for any IV injection, so-called chemotherapy and all. So these targeted therapies make adenocarcinoma a little favorable subset as compared to squamous cell lung cancer. So even you're asking the survival and prognosis depends upon many factors. So patient-related factors, tumor-related factors, and the response. So patient-related factors, yes, age is a factor, gender, males and females. So younger patient who has a better fitness level will do well because is in a position to complete the treatment better as opposed to a old patient who is already very sick, has some other cardiac problem and comorbidities because of which he is not able to complete treatment. Whereas a younger patient will do well who is fit, and females, non-smokers, adenocarcinoma subgroup does well if they have those mutations because those tablets, they can prolong life. They can add more years to their life. And coming to squamous cell carcinoma, it's little, the prognosis again, overall depends upon the stage of the disease, what stage they are diagnosed, and also what is the response to treatment. For any malignancy, if you see, it will definitely, response to treatment is one important factor which will decide how good is the survival. Good response to treatment means good survival, as opposed to a patient who has not responded to a standard therapy. Patient who has not responded, we have to again put them on second line therapy, third line therapy, and go on. But patient who have good response to treatment definitely will do better than patients who have not responded to the treatment.
All right. So I guess one part is your genes, and the mutation that you're talking about is, I guess, a factor of your genes, right? So, Dr. Ditya, then would you say to some extent your survivability in lung cancer is also, up to some luck. If you are lucky, you perhaps were diagnosed early. If you're lucky that you had the gene, you could take the targeted treatment and be better off. Could you talk more about the treatments? And ma'am said that they are oral tablets. They don't cause discomfort like chemotherapy would do. But can you do surgery and take the tumor out for lung cancer patients? Is that also an option? What is the treatment protocol like?
So there are three primary treatment modalities in the treatment of any cancer, including lung cancer. The primary modality would be surgery. That would be a curative intent of treatment. So any patient with a disease which is in the first stage, in the second stage, and probably in the earlier part of stage, which is called a stage 3A, these patients are probably subjected to surgery first, getting all of the disease out, and once everything comes out, making sure that it never recurs by consolidating the gains with some chemotherapy. So the primary modality in early stage lung cancer is surgery, with or without some chemotherapy, and with or without a little bit of radiation, depending upon the exact subtypes or characteristics. When you go beyond stage 3A, which is stage 3B or stage 4, in this setting is wherein we talk about non-surgical modalities. So in stage 3B, what we do is we give a combination of chemotherapy and radiation to treat. However, in stage 3B also, the intent of treatment is cure. We aim to get a cure, and nearly 30% of the patients are alive even at the end of 5 years of stage 3B lung cancer. The idea here is to sort of burn whatever tumor is there, and whatever tumor escapes into the bloodstreams, those invisible cells we call as the micrometastasis, they can be targeted by chemotherapy. Once you go beyond this is wherein all the fancy new therapies come into play. If you're talking about systemic therapies, it can be again subcategorized into three types. The first one is your conventional chemotherapy, which is given via an IV. It is just like getting any glucose infusions. Unlike popular belief, chemotherapy does not mean something burning is directly injected into you, or something very painful is being injected into you. It's just like any other glucose infusion. When you talk about targeted therapies can either be by an injectable form or the more widely available and also the more effective oral form. So these oral targeted therapies are known to act on only the cells which have the genetic mutation. So by definition, they spare the normal cells in the body, which means that we don't have the side effects of chemotherapy like hair loss, like nausea, vomiting, low blood counts. None of those conventional side effects of chemotherapy are there with target therapies. There may be some specific side effects of these target therapies, but most of them can be managed very well. And then we move on to the newest bullet in our gun, which is called as immunotherapy. And quite a few medical companies, including Roche, is at the forefront of this. In immunotherapy, what we do is we try and activate the body's immune system to fight against the cancer. So body has an innate immune system, which the tumor somehow suppresses by secreting a chemical. What immunotherapies do is that they break this bond between the tumor cell and the immune system. So the immune system becomes freer to go and attack the tumor and achieve reasonable tumor control. So this is this whole spectrum of treatment across stages. In stage 3 or stage 4, very rarely we consider surgery. And even if we do, it would not be for the primary lung tumor, but if there is some kind of a tumor in the brain which is pressing somewhere, maybe that time we might do, but otherwise surgery is generally not an option in an advanced stage. Thank you.
Oh, so surgery is not really an option. Dr. Poonam, how many of your patients go through surgery?
So surgery, definitely it's an option only for early stage. And early stage we don't see. So definitely it's not an option. It's as simple as that. The thing is, surgery is done only for to decompress the tumor, to reduce the tumor size only if it's in the locations like brain. And otherwise surgery is not done for advanced stages. in early stages of lung cancer, surgery is completely curative, meaning stage 1 and 2, if the tumor is removed, patient may not need any further treatment at all. So actually, in this COVID times, we had a few patients coming up with CT chest reports and all, and we were very surprised to see early stage tumors because the CT chest was done for something else, was done for COVID monitoring, but there was a small tumor found. So both these patients, they had like stage 1 tumor, stage 1 to 2 tumor, and they got operated and they are doing well without any treatment. So early stage tumors we do not find, but as and when we find, surgery is an option only for them. Advanced stages, it's only to decompress the tumor if it's located at a very subtle site, very vital site like brain. Otherwise, surgery is not an option.
Right. Dr. Ditya, you talked about the different kind of treatments that are available and how technology is also helping us in developing targeted therapy, immunotherapy, and now all these modalities exist. But Dr. Puran said that this is an aggressive cancer. So does this spread to other organs as well? And then what do you do? I mean, then how? I mean, you can give targeted therapy for the lung cancer, but it's spreading elsewhere. Then you'll have to go chemotherapy and the other way, right? I mean, what do you do when it starts spreading fast to other parts of the body?
So, uh, if so, the targeted therapy, by nature, it is going to go and act on the tumor cells which are there in any part of the body, not just on the lung. It can go and act on the tumor cells which are also there in the brain, also there in the bones, and all these other areas. So, the commonest sites where the lung cancer usually spreads is the bones, the brain, and another organ in the body called as the adrenal. So these are three common sites where lung cancer spreads. There are some scenarios wherein if there is only one site of cancer outside of the lungs, what we call as a oligometastatic disease. In such a scenario, we try and give these target therapies, bring the primary tumor under control, and if necessary, give radiation to that area, that particular area. So let's assume that if there is one tumor area in the lung, or if there is just one painful bone area where there is the lung cancer has spread, then to these areas we are able to target them with precise radiotherapy mechanisms and burn those areas off. So that is one thing that we can use to target. But target therapies are also usually effective in treating cancer at other sites.
That's good to know that the targeted therapy helps to treat the tumors and other sites as well. Dr. Poonam, what is the role of immunotherapy in cancer treatment? Is it widely practiced and easily available? What are the costs involved and how effective is it?
Yes. Immunotherapy has come up recently, meaning in the past 2 to 3 years, and it has really revolutionized the treatment because the side effect profile of immunotherapy drugs is not like chemotherapy. The side effects are totally different and they are very well tolerated. Now, immunotherapy, there are many types of immunotherapy, and how it works, that is also very nice. Dr. Aditya already mentioned it enhances the body's own immune cells, that we have immunity cells in our body. So these our own immune cells are enhanced to work against the cancer cells. So tumor cells are attacked by our own immunity cells, which are enhanced functionally by giving this immunotherapy. This is also mixed in like glucose solutions and given in IV. So this immunotherapy, definitely the side effect profile is not like chemo. So side effects like nausea, vomiting, hair loss is not much, is nil, completely nil. There are completely different types of side effects, but by and large, they do a very good response. We have seen very good responses with immunotherapy, and not only in lung cancer, but it has come up in almost all the solid malignancies. Immunotherapy has come up in a big way. Now, as I said, it has come in the last 2 to 2.5 years, maybe. So the cost of the treatment is quite high currently. But from the company, there is good patient assistance program. So the cost of therapy is somewhere between 2 to 4 lakhs per month, approximately. And The patient assistance program will be like one they purchase and one they get free, or two they get free. So overall cost, if you see, in a month comes to around 1 to 2 lakh per month. So with the continued use of these drugs, as it happens to any other drugs, the cost will definitely come down. And when the cost will come down, even more number of patients, it can be made accessible and affordable.
All right. We've started getting some questions. So, Dr. Ditya, I would like you to answer this one. I'm not very clear on this question. It's come from a Facebook user. He's asking, what is the role of gut dysbiosis in cancer onset and cancer risk? Gut diagnosis or dysbiosis. Am I reading this right?
What's the spelling?
dysbiosis.
So I am assuming they're talking about the innate bacteria in the gut, and how the chemicals that they secrete and how that acts or interacts with the cancer formation. So um, so human intestine is home to millions of organisms. Okay, and some of them are beneficial, and they do produce important chemicals which are quite helpful in maintaining the normal movement and the function of the intestines. Along with that, it may also be helpful in certain types of blood related cancers. However, I am not aware of any role that the gut bacteria has to play in formation or treatment of lung cancer.
All right. If there are more questions that you have, just type them into the box of this live session, and our doctors are here to help answer some of those questions. So you said, Poonam ma'am, that there are these, patient assistant programs. When it comes to access of medicine and the treatment, uh, the government says that basic chemotherapy and all of this is generally covered for free for patients. When if it is for a lung cancer patient, how much say in a government center or tertiary center, what kind of treatment is available which users can afford, and how much is their life then prolonged?
So immunotherapy, certain government bodies, certain government health insurances like CGHS, Southwestern Railways. So there are some government body which will approve these therapies. So meaning patient will not have to pay anything. It will be free. So unless they approve, so if they approve and they only give the medicine, then the treatment is absolutely free. But not all. The private insurance and all that, patient has to bear the cost. I mean, it will be covered under their insurance, but insurance will not be enough for that much of cost. So here, patient assistance program really helps. And not in immunotherapy, but in some drugs, it is like if you take 6 months, then it is lifetime free. So there are good patient assistance program coming up, and I hope that with the increasing usage already there, the cost will definitely come down, and more people will be able to afford. And not all government body insurances are approving. This is also one challenge. So few are approving and few are not approving. Those who approve, they get absolutely free treatment.
All right. So perhaps there will be some uniformity going ahead in how immunotherapy can be claimed under your insurance, or whether the cost can be borne by the government when it comes to treatment in the government hospitals. Dr. Ditya, we've spoken about treatment, we've spoken about symptoms, but let's speak a little more about being aware of lung cancer and how you can protect yourself from lung cancer. Now, in our country, we're seeing more and more people being diagnosed at a younger age versus what we see in Western countries when it comes to cancers, not just lung cancer, other cancers as well. Some people say this is a factor of our younger population, but we have to deal with it. So, what can we do to reduce our overall risk of getting lung cancer? Quitting smoking is definitely one, and disincentivizing smoking is definitely one of the ways to do this. What else could people do if they don't smoke at all? How can they try to reduce their risk?
I think an holistic approach is what is going to get us through over here. I read some incredible statistic recently saying that nearly two-thirds of all cancer deaths could be prevented just by doing three things: eat well, sleep well, exercise well. So just by doing the three basic things of eat, sleep, and exercise, we can prevent two-thirds of cancer deaths. So taking this more seriously, what is very important is that all of us should aim for getting at least 30 minutes of exercise 5 days a week. That is at least to start off with. Try and make sure that we eat healthy. We avoid junk to the extent possible, and it's not just junk food. I mean, junk food may not be such a big factor in many malignancies. It might be more of a factor in heart diseases, but reducing the use of pesticides, reducing the use of plastics, reducing the use of Teflon, trying to ensure that we procure organic stuff. So these things will also go along with the problem with all of these steps is that none of them give immediate results. Okay, so just like it takes decades of bad habits to lead to a bad result, it takes decades of good habit to lead to a good result. So we need to start living right. I think the pandemic has been a big wake up exercise for the whole mankind, and we are trying to move towards more sustainable solutions, going carbon neutral, trying to make sure electric vehicles are taken. That is a very significant thing even for a place like India, wherein pollution is tremendously high and implicate in a whole host of diseases. So the steps that we need to take is a small steps. We need to be consistent, eat well, exercise daily, try and stay healthy, and that will itself carry us through a long way.
Right, Dr. Puram, and I think Dr. Aditya also, both of you spoke about the role of pollution. Dr. Aditya talked about, how to PM2.5 gets lodged into your lungs. But Dr. Puram, there are, I think, equal number of people who come with lung cancer from rural areas also, where the pollution may not be that bad. So, I mean, what role does pollution have to play? And I mean, how can you try to protect yourself? I mean, there is air purifiers, but not everybody can afford it. So, do you think it can be conclusively said that pollution is one of the big reasons that we're seeing an increase in lung cancer cases?
These are all contributory risk factors. Nothing can be proven because, as you said, people who are coming from villages, there is no pollution. But yes, there is different kind of smoke. There is different kind of environment. The burning of the charcoal or the biomass fuel, all these also adds. But yes, overall pollution factor is very less in villages. Then why people from villages do get? So this pollution or smoking is not the only risk factor. That's what we are trying to tell. Even in cancer, the main risk factor or the main cause, if you ask, like people ask to us in OPD, why I have got lung cancer or why do I have cancer? I don't have any family history. I don't have anyone in my family. Why do I have cancer? So family history is not important, is not the only risk factor for any cancer. Even your risk factors like smoking, pollution, these are a contributory. You may not have any risk factor and still you may go on to become have cancer. So these risk factors are just contributory and proposed risk factor. So even when there are no risk factors, cancer can come. And few of our patients are so fit, as I told you, they don't look like patients. Some of them are school teachers, they are IT professionals, they are gym experts, they are trainers. So they are that fit body and that fit, good, healthy lifestyle, and still they are cancer patients. So nothing is proven, and we need to take care of whatever can be taken care, like these simple steps which Dr. Aditya told. Yes, all eating right, eating well, sleeping well, healthy lifestyle. So all this is important because at least these we can take care. Whatever we don't know, obviously we cannot take care. So these contributory risk factors, definitely it cannot be told that yes, this is contributing 100%. We have to be aware of our body. If anything is going wrong for a long time, please get it checked. Don't hesitate yourself to meet a doctor or a professional. And cancer is not a death sentence anymore. That has to be stressed because patients are living with treatment. They're going back to their offices, working normally. If you remember when HIV came like a big bang, and people used to segregate whether they'll work in office, whether they'll mingle with others. Now, if you see, HIV is not a big concern. People are taking their treatment, monthly tablets, free tablets at various ART centers, going back to their work. None of the patients waiting at the ART center look like patients. So, to go on, even cancer is becoming a chronic disease like diabetes and hypertension. And the scare factor should reduce. And this kind of awareness program, what we are having today, definitely with the general public, is to reduce this fear factor.
Right. Dr. Ditya, reducing the fear of cancer so that people may take timely treatment and consultation with the doctors is one of the reasons why we're doing this awareness campaign. But, it all has to be a mix of carrots and stick. Like if you kick the butt, you will reduce your risk of cancer and many other diseases, but people still continue to smoke. The disincentivizing, do you think that has to be stricter coming in from the government? Uh, and what are the other incentives that can be given so that people lead a healthier lifestyle and put all these lifestyle related diseases away from themselves?
I think government activism has only picked up in the last decade or so. That's when Supreme Court said we should ban chewing tobacco, and from then on, probably activism has picked up. All these messages which are played at the start of a movie or when somebody smokes. So all these things are only been enforced in the last 10 odd years. Just raising the price of a pack of cigarette is not going to make too much of a difference. I think 20 years back a packet of cigarettes was about 25 or 30 rupees. Today it is 10 times more expensive. It's probably 200 to 50 rupees. So that is one aspect to it. Above all, people are most, the best form of disincentivizing is by making it uncool, making it absolutely uncool in the sense that, there has to be a social stigma to it. Uh, People should never ever feel that, smoking is an answer to a question or it is cool. So apart from the financial damages, apart from the criminal punitive measures, if at a societal level, if at a very young level, if at the school level, we keep enforcing the message that this is bad, this is bad, this is bad, there would be no reason for somebody to go to it. I mean, just compare this with something like cocaine or hard drugs. So with hard drugs, people, that the message has been true and clear that it is not good for health, and people are not even that interested in pursuing those things. So it has to be a lot of stick, and the stick has to be at a social level, at a young level, as well as a government and a legal level.
All right. We've started getting some more questions. Dr. Poonam, I would request you to answer this one. One Facebook user is asking, what is LDCT screening?
Yeah, that is the low dose CT chest screening, what we spoke about. The normal CT scan of the chest, which we ask to diagnose any condition, has a higher exposure of X-ray radiations. So low dose CT chest is to minimize the risk of having those radiations, because radiations exposure over a period of time itself is a risk factor for developing some malignancies. So low dose CT chest is an answer for that, wherein the exposure to radiation is less.
All right. Dr. Titya, would request you to answer the next question that we've got. And a Facebook user is asking, can you please throw some light on the median survival rates of lung cancer patients? Is there a median for all ages? Is it different for ages? Can you give some stats here?
It is different for ages and types. The most common type of lung cancer, which is the adenocarcinoma, has a median survival of about a year and a half. The type of cancer which is seen prominently in smokers, which is called as a small cell lung cancer, has got a median survival about 10-12 months. There are other rarer types of cancers, and depending upon other factors like the age, like the fitness, the tolerability to treatment, it could vary anywhere between about a year and a half, with some outliers going beyond 3 to 4 years.
Okay. So 3 to 4 years is also a possibility.
It's a possibility in certain subsets for sure.
Okay, Dr. Poonam, another question coming in is, how fast does lung cancer grow? Can annual screening help in early detection? Dr. Poonam, would you like to take this?
So how fast lung cancer grows? See, if it's a small cell lung cancer, it's very aggressive. So it grows very fast, maybe within few months. And few other cancers, see, exactly nobody can measure or say that this cancer grows over these many days or months or years. But as compared to other non-small cell lung cancer, small cell lung cancer grows very fast within few months or days also. But other cancers may grow slowly over a period of few years before they become symptomatic, because early stage there will be no symptoms. What was the other part of the question?
Can annual screenings help in early detection?
So annual screening, yes, the question is right, because suppose if the cancer is growing within few months, then how is the annual screening going to help? That is why we mentioned that annual screening only for the high risk individual. So it's not like you don't have any symptom, you have never smoked before, and you go on doing all the x-rays, all the CT chest every year. So your doctor will prescribe the test as and when it is required, after assessing your risk factors, whether you have any symptom, whether you have any weight loss or cough or anything, and if you were a heavy smoker, then frequent. Otherwise, it's not like every year you have to go for CT chest. It's not like that.
All right, Dr. Ditya, we'll take one last question, which is, what is the life expectancy of someone with stage 3 lung cancer? Now, we spoke about the luck factor, about the mutation which you have or not, and how targeted therapies can work to prolong your life, plus immunotherapy as well. So, is there a time range that you can give for a patient who has come in stage 3 lung cancer?
So stage 3, again, there are two subtypes. There is stage 3A and stage 3B. If it's a 3A type, you're looking at about a 30 to 40% 5-year survival. If you're looking at stage 3B, you're looking at about a 20 to 30% 5-year survival. And in cancer, cure is defined as somebody living for at least 5 years after the diagnosis of cancer. And above all, doctors, just like everybody else, are human. We believe in God as much as anybody else, and we pray before we treat anybody else for as much of luck as much the medicine does. So it's always dawa and dua.
All right. I would like to thank both of you for coming in today and answering all the questions that you've taken up and spoken about lung cancer, how it can be diagnosed, what are the modalities of treatment, and upcoming therapies that could also work wonders. We're keeping our fingers crossed that these therapies coming quickly, diagnosis is swift, and the burden of lung cancer in our country reduces. Big thank you to Dr. Poonam and Dr. Aditya for joining us today. Thank you so much.
Thank you.
Do stay tuned to the IHW Council page. Do like it and follow it. And if you have any questions about lung cancer, type them in. We will try to take them up at a later discussion if it is possible. Thank you so much for watching. Stay tuned to IHW Council and stay safe at home. Goodbye.